Hello, hello, everybody. Hello, good to see you. Good afternoon. Happy Tuesday. I'm going to give you all a minute to get connected. I see lots of people connecting to audio and getting their video up. So I'll give you all a chance to get situated. My name is Anissa Mitchell. I'm with PMD Alliance, and I want to welcome you to our program today. We're doing a spotlight today, a deep dive into what Duopa is. And with us, we have three guests. And before I introduce them and get kicked off into this program, we are going to invite you to ask questions throughout the program today. It's going to be interactive. So if your question is pressing and it's going along with the conversation, we're not going to wait until the end. We're going to ask it as we go along with the conversation. So we're going to do that through chat. So if you would just open up your chat box at the bottom of your screen where you see the little chat icon, click that open. And that's where you're going to ask your questions today. And I would love it if you would give a shout out and let us know where everyone is joining us from, because we've had people joining us from all over the US and even in other countries. We had a couple of times I've seen Australia on Canberra. So it's like really cool to see where people are joining us from. So give us a shout out. And while you're doing that, I'm going to introduce our speakers today. We have three people that's going to be sharing about Duopa today. First with us is Dr. Maria Christina Ospina. She is a movement disorder specialist that you might recognize, as she has been on our programs before. She's one of our favorite partners that we love having be a part of our programming. And she is a movement disorder specialist in private practice. She's also an assistant professor of neurology at the University of Arizona. She is in the Phoenix area, and she's been active in medical research, including several NIH studies and pharmaceutical sponsored clinical trials, and serving as an investigator for the Parkinson study group. So we are so happy to have Dr. Ospina. Hello. And then we also have with us today, Kaler Ray. So Kaler is a gastroenterology physician assistant, and he is at Banner Health in Phoenix, Arizona. And he's going to be talking to us about the surgical side of Duopa. And then we have Brian Ford. Wave, Brian. He is a person with Parkinson's. He's joined us to talk to us about the user experience, somebody who's actually had Duopa and can share a little bit about what it's like to have gone through the procedure and live life with Duopa. So welcome to all three of you. All right, I'm going to go ahead and start off because we have a lot to cover today. And again, I'm going to encourage you all to ask questions as we go. But let's start off with Dr. Ospina. If she could first just break down to us and explain what is Duopa, why does it work more effectively maybe than taking more carbidopa, levodopa pills?
Okay, thanks, Anissa. So what is Duopa? So Duopa is a gel form of carbidopa, levodopa. So the same medicine that you're taking in your yellow cinnamon, or as Rytari, which is Rytari are capsules of immediate release and extended release carbidopa, levodopa. Duopa is a gel form of that same medicine that's delivered through a medication port straight into the small intestine where it needs to be absorbed. So remember, what causes a lot of the motor fluctuations in Parkinson's disease are the peaks and troughs that you get with the oral medicine. So remember, in Parkinson's, you have bradykinesia, or slowness of movement, and that involves all of the muscles of the body, including the muscles of the gut. And because your gut has become slower, it's the reason why PD patients have constipation. So the gut, everything moves slower in the gut, more fluid gets sucked out of the stool gets hard, and you get constipated. And then that gastrocolic reflex doesn't work anymore. So you swallow your pill, and it should enter into the small intestine right away in 15 minutes or so. But sometimes in a Parkinson's patient who hasn't had a bowel movement in 3 days, it can take up to 90 minutes or more. And that's why you notice that somebody's, gosh, I take my pill and nothing happens. That's called a delayed on. It's because it got stuck in the stomach, and it actually gets absorbed in the small intestine. And so we have to wait for that transition to work. So it's the reason why your doctor picks once a day medicines. It's not that we want to pick the most expensive drug that's out there in the market. We want to pick drugs that work like the normal brain. So we want drugs that work the 24 hours a day. But when patients are taking Sinemet 6, 7, 8 times a day, and then we've transitioned you to Rytary, longer acting forms of levodopa, and you're on Rytary 5 times a day, and you're still having wearing off an hour before your next dose, then we would consider Duopa to give you an infusion of levodopa. And so you're not peaking and troughing throughout the day every 3 or 4 hours when you take your medicines. So it's a much smoother transition for your medicines, and it works more like the normal brain. And so remember, by the time you come and see your doctor, your neurologist, for the diagnosis of Parkinson's disease, 60% of those cells that produce dopamine have already died off. And so we're left with 40% of those cells remaining, and that as the disease progresses, those cells continue to die off, and we have to replace more of the dopamine with the medication. So many patients come into the office and they say, well, I read on the internet that after 5 years or so, the Sinemet, the levodopa doesn't work, so I don't really want to start it, or I want to hold off on it. It's not that you develop a tolerance to the medicine or you habituate to the medicine. Is that what happens as the time goes on and your disease advances? You lose those dopamine producing cells, and we have to replace more of it with the pill. And because pills go through the gut, through the tummy, and they get slowed down, that's what causes these peaks and troughs and these what we call wearing off. So Duopa is one way to bypass that slowed gut, because we're putting a medication port straight into the small intestine where your levodopa is actually absorbed. And that way we have a much smoother absorption of the medicine. And so as that therapeutic window gets smaller and smaller, we're not peaking above it, so you have on time with dyskinesia, and you're not troughing below it, so you're off. And then it takes a really long time for that off to go away, because we're waiting for that pill that got stuck in the stomach to transition into the small intestine.
So Dr. Ospina, can you talk a little bit about what the sweet spot is? So you've talked about the peaks and the troughs. So you can tell everyone what that
maybe, is. I should have, I actually have a graphic. So let me see if I can share my screen, and then I can show you it so you can see visually what that looks like. Okay.
Oh, we do have somebody from Canada joining us today.
Okay, can you see my screen here?
Yes.
Okay. Let's see. So this is what the sweet spot is. So when you get diagnosed with Parkinson's disease, you're over here. The doctor says, hey, you have PD because you have the motor symptoms of Parkinson's. So you have tremor, rigidity, bradykinesia, which means slowness of movement, and trouble with gait and balance. And so you've already had 60% of these cells that produce dopamine have already died off. You've already had PD about 10 or 15 years. And so we're left with these 40% of cells, but they continue to die off as the disease progresses. And so we have to replace that medicine, that dopamine, with the medicine. And remember that the medicines are purely symptomatic. They just treat the symptoms of the disease. They don't stop or reverse the disease. And that's why we always advocate exercise for our patients, is to try to slow down this disease progression. And then of course, exercise also helps constipation. And so as the disease progresses, you get started on Sinemet here, you take 1 tablet 3 times a day. You may even forget that noon dose and not even notice, because look how big your therapeutic window is. But 5, 6, 7 years later, you're over here. And if you miss a dose, gosh, you trough all the way down here, and it takes a really long time to get back up. And so that's why using something like Duopa, where we have very fine control over your dose. Remember, once you swallow a pill, we can't get it back. So once you swallowed your Rytary, your Sinemet, it went in there, and it may take up to 90 minutes to kick in. See that what's this? This is a pill, a cinnamon pill that somebody swallowed 90 minutes ago. So that's a delayed on. That's somebody who took their medicine and nothing happened. And then when the patient gets to the point where when I swallow and take my pill, I don't know when it's going to kick in or how long it's going to last, then Rytari is a really good option for us because we have very good fine control over the pump. And then we can give you an extra dose if you fell over here, we're doing rock steady boxing or anything like that. And we can push you up a lot faster. Let's say you took too much and you have on time with dyskinesia, we can turn down the continuous dose on your pump, or we can turn it off and get you back into this therapeutic window. So it's much easier to control your dose with a pump than it is with the pills, because once you swallow the pill, we can't do anything about it. We can't get it back or change that dose. Whereas with the pill, we can, every 57 seconds, you're getting a dose of levodopa, and that's how quickly we can change the dose as needed. So this is what the sweet spot is this blue area here where you're on, and on means that your PD symptoms have gone away. You feel normal again, whereas off means that your PD symptoms have come back, and that's both motor and non-motor. So things like tremor, rigidity, and slowness, and your non-motor symptoms like anxiety, paresthesias or numbness and tingling, that sort of thing. And so many times your first sign of off is not the tremor, it's that anxiety or paresthesia. And that's when we want to pick up and take your next dose. But it's much harder to regulate your dose if it's a pill. Oh, Anissa, you're muted.
Oh, sorry. I thought I unmuted myself. I muted myself. Sorry about that. So off. I know that we talk a lot about this, and I imagine that everybody kind of experiences that feeling maybe a little bit unique, and there's different types. So you already mentioned like wearing off and delayed on. So can you, I know we go through this a lot, but there's always, still a lot of questions that I see come through from people. Like, can you describe the different forms of off, like the wearing off, the delayed on, the failed dose failure?
Uh-huh.
Yeah. Mm-hmm.
And remember that your off is not just motor. So always people think, oh, it's just when my tremor comes back or when my stiffness comes back. Remember, your non-motor symptoms are part of off as well. And many times the non-motor symptoms come back earlier than the motor symptoms. So just like you can have bradykinesia, which means slowness of movement, you can have bradyphrenia, slowness of thinking. So many times it's the care partner that notices, gosh, I'm asking you a question and it's taking you a long time to process the question and answer the question. And so that just means that you have bradyphrenia. That could be your very first sign of off. Or you could have anxiety. So many times anxiety is part of off, and people don't recognize it as part of their Parkinson symptoms. And so they don't treat it. And so they wait until, is the screen sharing still on?
No, we took it down unless you need it back, only just because that way everybody can see you better.
Oh, okay. So let me go back to so I can describe the different kinds of off.
Oh, absolutely.
And so that, and then remember,
you'll have to reshare though. I'm sorry.
What's that? Oh, I have to reshare. Okay. Mm-hmm. So many times people don't recognize anxiety as part of off, and then they wait until the motor symptoms come back and the tremor comes back and they're way down here. And so now, we're like an hour into your off, and it's going to take a really long time to climb back up. So that's one reason to use Duopa or use rescue medicines that bypass the gut and get you back into the sweet spot earlier if you didn't recognize you're off, and then take your next dose accordingly. So one of the very first signs of off is end of dose wearing off. So you started off taking Cinemet 3 times a day. And then in the beginning, you could even miss that noon dose and not even notice. But then 5 years later, if you missed a dose or you were late with the dose, then you fell over here and you would say, gosh, 30 or 40 minutes before my next dose, I wore off. And then your doctor will say, okay, let's take the medicine instead of 3 times a day, then 4 times a day, because we're treating your end of dose wearing off. We're going to bring these doses closer together so that you're not troughing in the off period. Then you can have delayed on, like Anissa said, and then this is the delayed on. So remember that you swallow the pills, they go into the stomach, but they don't actually get absorbed until they get into the small intestine. And so if you have lots of constipation, that gastrocolic reflex isn't working, or you have a lot of gastroparesis, which means a slowed gut, and then you swallowed the pill and then it's got stuck there, it stayed there for over an hour, then that's a delayed on. We took the pill and it took forever to kick in. Or you took the pill and you ate a lot of a big protein meal and then it just took a long time to absorb because it gets absorbed in the small intestine and it gets absorbed through this amino acid transporter that competes with protein in your food. So if the protein got there first, you may notice that your levodopa is delayed in the absorption. So that's why some patients will take their Sinemet first, their levodopa first, and then eat afterwards. With the pump, then we don't have to worry so much about when you eat and what you eat. And then Brian will tell us a little bit about how his experience has been with food and taking levodopa. So then the other form of off is morning off. So usually you're taking levodopa throughout the day. And so that you're peaking and troughing and taking medicine throughout the day, but then you don't take any medicine at night. And so then when you wake up way down here, you're off. And then it takes a long time for that first dose of levodopa to kick in. So many times we'll use a rescue medicine to start the day so that we bypass that gut and get you back into therapeutic dose, or add medicines in the middle of the night. And then Duopa has a morning dose where we can give you a bolus to get you back into the sweet spot and then stay there for the rest of the day. So that's morning off, when it takes you a long time to get ready in the morning and for those medicines to kick in. And then the other form of off is unpredictable off. So remember that your levodopa is like gas in the car. So if you drive your car at 80 miles an hour, then you use up more gas than if you drive at 50 miles an hour. And so you'll notice that when you go to Rock Steady Boxing or your physical therapy, or there's some kind of emotional stress, you burn through that levodopa faster. And then instead of the medicine lasting the 3 or 4 hours that it usually does, when you're at home watching Netflix, it only lasts 2 to 3 hours. And that's the unpredictable off. And so again, having something like Duopa, and we can add Duopa, the pump. Not only does it have a bolus for the morning, but it has an extra dose, so that if you burn through it through your Rock Steady Boxing class, or your dog passed away, then you can add an extra bolus and then stay in the sweet spot and not keep falling below it. So those are the different kinds of off. And remember, it's both motor and non-motor.
And Dr. Ospina, we had a question. Someone wanted to know, what if your symptoms are actually a bit better in the morning, still not great, but better?
Yeah, so some people, remember that sleep is restorative. So some people, they actually feel better in the morning. And then as they start to take the medicines, they get more sleepy and tired. So we just adjust your medications accordingly. So most patients have morning off. There is a subset of patients that feel better in the morning and then get worse as the day goes on. And then your doctor would adjust the medicine.
Awesome. So I have a question now for Brian. So Brian, I would love it if you could share a little bit about your experience. What was your off like? Was it gradual? Did you have delayed on in the mornings? What was your experience?
Before the Duopa?
Yes.
Okay, so I was on the Sinemet for, I don't know how many years it was, Dr. Ospina, but that was working flawlessly for me. I mean, I was taking 3-4 a day and I had no problems at all, but also with the patch. The, what was the name of that patch?
Nupro patch.
Yeah, the Nupro patch. I was doing the Nupro patch and the pills, and I thought I was, oh, this is easy. I'm thinking this isn't really that bad. And then one day I experienced like hallucinations, that things that weren't real. And then that was kind of my kind of cliff when things started changing for me. So then I got off the patch, and that's when I started really experiencing like the cliff. I'd take the pill, like Dr. Ospina said, and the second I'd eat anything, it would just be like a wall. Everything would come to an abrupt stop, and I would just be, I'd be confined to a chair and just kind of wait it out. It's pretty awful. And then, it took me probably 6-7 months to really figure out what was really going on, but it was the protein, I think, is what we kind of came to the conclusion of. So yeah, that became an awful experience because your life becomes, you got these small windows of when the pill's actually working, and living your life around that certainly wasn't fun. So that was for me, and it just was in my face. I couldn't avoid it, and that's why I went to the Duopa. It was a pretty easy choice, actually.
And Brian, this is kind of a question for you, but also a question for Dr. Ospina. I imagine with having a lot of on-off fluctuations, and however it presents for a person, that it can be very frustrating and can impact their social life, their quality of life. So I guess my question for you, Brian, is what made you finally want to get Duopa? What was like your last straw?
Well, for me, it was, I'm always, I always try to fight through things. I can get through it. I can do it. I can do it. And you come to a conclusion of, this is not a really great existence. And I remember Dr. Ospina says, you don't have to do this. Like, there's another option. But then of course you explain the tube, and you're kind of like, I don't know about that, the body image, the tube. So you're just continuing to fight through it. And one day I just told myself, I'm like, well, the big thing, to me, back up a little bit, Dr. Ospina did say, this is all reversible. If we put it in you and you hate it, it can all come out. It's not permanent. And that gave me a little bit of like an insurance policy, like, okay, if it doesn't work, certainly, it could be removed. So I guess psychologically for me, that helped quite a bit. But yeah, for me, it was just like, I cannot continue to live in 2-hour windows. It became so blatantly obvious for me, because I really went from very little symptoms with the pills to it all just came crash. It was like I just crossed a cliff.
Right. So we want to avoid the patient's life being interrupted every 3 hours by the medicine wearing off. And so that we want to, throw away that smartphone that has the 6 alarms in it, and that you're always planning your day around the alarms on your phone and when you're going to be on, and then not knowing how much on time you're going to have. So then you end up staying at home because you're like, oh, I don't know if I can make it through Costco and the whole shopping experience. I'll just stay at home. So this is one way to avoid that. And as Brian said, is reversible. For whatever reason, you don't like to be on all day long, then we can take it out. So I mean, once you go on the pump, you don't realize how much off time you were having anyway. And very few people, almost nobody, goes from the pump back to oral medicines.
And you can do a lot of things with this pump. I know that's a big fear for some people. They can't, maybe participate in activities, go for a swim, things like that. So can you explain if there are even any limitations with the pump?
So you can go for a swim. So remember, your pump, you attach it to the PEG-J tube, but you can always detach it from the PEG-J tube and then just cap off the tube, and then you can swim. If you're off the pump more than 2 hours, then we give you some oral medicines. If you're under 2 hours, you probably don't need any. But you can, we don't like you swimming in lakes and that sort of thing, but you can go swim in the pool, do your water aerobics. So there's a lot of flexibility that way.
Great. So Dr. Ospina, what are the steps that a person who's interested in Duopa need to take in order to get to that point?
So it's not a big workup like it is for DBS, where we have to do an MRI, neuropsych testing, those sorts of things. Anybody who's taking Rytary more than 5 times a day is a candidate for Duopa. And so if you're planning your day around your doses of Levodopa, then you're somebody who would benefit from the pump. And then you can always try it. Remember, it's reversible. So after 8 weeks, if you decide, oh, this isn't for me, we pull the tube, the stoma closes, and we're back to taking oral medicines. So you can always try it. You're not married to it once you try it. But anybody who's taking Rytary more than 5 times a day would be a candidate for Duopa, so that you have more continuous dopamine infusion throughout the day. And you're not so worried about what I'm going to eat, when I'm going to eat it, how long are these pills going to last, and that sort of thing.
And you've mentioned Rytary. So if someone wasn't taking Rytary and they were just taking a bunch of immediate release carbidopa, levodopa, what is the number of those pills that you would look at as maybe time to consider?
So yeah, let's say you're taking, it's hard to take something 6, 7, 8 times a day. So if you're taking Cinemet 6 times a day, 7 times a day, then we would offer Rytari, which is a longer acting form of levodopa. And then if you're taking that more than 4 or 5 times a day, then we would consider Duopa. So, I mean, if we can go from taking Cinemet 7 times a day to Rytari 4 times a day, then we'll do that. And then we would go to Duopa after that.
Yeah, because we had a question, if someone has experienced hallucinations, are there any concerns in using Duopa?
No, so as Brian said, one of the problems that he had with the medicines, as the disease progresses, we have to increase the dose of medicine that you're taking to treat the symptoms. And that, remember, the medicines helps the motor symptoms of PD, tremor, rigidity, bradykinesia, or slowness of movement, but it makes the non-motor symptoms of PD worse. So it can cause more hallucinations, confusion, low blood pressure. And so our job is to try to get that balance just right, where you have enough medicines on board that you're mobile, but not so much that you've become psychotic or paranoid, or that every time you stand up, you faint from low blood pressure. So with the pills, it's harder to manage your dose. With Duopa, we can give you just enough to keep your motor symptoms controlled, but not so much that you're always peaking and you have on time with dyskinesia or you have hallucinations. So it's much easier to control your excess side effects with Duopa than it is with oral medicines.
Awesome. All right, now I want to move over to Kaler, who is, like I said, he is a gastroenterology PA, interventionist. And so I want to know from you, Kaler, once a person's been referred to get Duopa, if you can share a little bit about the surgical procedure itself, like where the PEG J is placed, how that's done, how long does the procedure take, those kind of things.
Yeah, absolutely. I'm not on top of my game like Dr. Ospina. I've printed out a piece of paper here to show, but here, let me see if I can adjust this a bit. But yeah, so typically when somebody gets referred to us, we can either do a consult in the office or we can do something over the phone. And you'll talk to either myself or the physician that does the actual procedure, Dr. Sugamar. And so what happens, so I'll hold this up again. So, so here's kind of the human body. And so what we do is we typically pass an endoscope, which is about the size of a pen. So that goes through the throat and down into the food pipe here. Once we get through the food pipe, the esophagus, we start taking a look around the stomach. And what we're looking for is a good spot to make a small incision to where this medication port goes. So once we do that, the endoscope has a bright light on it and a camera. So we're looking on the inside, but the bright light actually allows us to see the scope from the outside. We can see your stomach while you're on the table and we see the light. And so if we find a good spot, that's where that's where we'll make the incision. And ultimately that's where the port will go. It's called a PEG J tube because, like Dr. Ospina was saying, the J tube goes into the small intestine. So the stomach here goes into the small intestine, and that's where your things like food and medications, that's where they're absorbed. That's where the nutrients are absorbed. That's where medicines are absorbed. And so from the PEG port, there will be a small little tube that goes into the second portion of the small intestine, the jejunum. And that's where the medicine ultimately gets fed into and absorbed by your body.
All right, so how long does the procedure usually take?
Great question. Typically, so we place these pegs for numerous amount of reasons. Typically, the procedure will be about 30 minutes, maybe 45 minutes. When we do these J-tube extensions, it can be, an additional 15 minutes. So I would count on something like 45 minutes, if not quicker, give or take 15 extra minutes or so. But it's not an extensively long procedure. It's not like a surgery where they can last hours. It's typically a pretty basic thing that can maybe be up to an hour tops.
And this is an outpatient procedure?
Yes. So Two different procedures that we have are inpatient and outpatient. And inpatient is when, you get admitted into the hospital, we bring you down, do the procedure, and then you get sent back to the hospital. This is not that procedure. So this one, you'll typically come in morning of, we'll do the procedure, and then you'll leave about an hour after the procedure is completed.
And how long is the recovery typically once the surgery is done?
Yeah, so recovery, they'll keep you in what's called the PACU. It's where we let our patients that are just finished with an endoscopy procedure hang out. That's where they monitor, let you wake up, kind of come to your senses, go over educational materials and stuff. And so typically they let you sit there, lay there for about an hour. But once you're with it and everything, then you're able to leave after that.
And then post-surgery and after you get out of the hospital and you're at home, is there any like wound care or anything that's required? And what's the length of time that you might expect that?
Yeah, so I know oftentimes that's a pretty big concern for patients is, how do I manage this new medication port that's hanging out in my stomach here? And it's not terribly difficult. Some of the pointers that we give, or wash your hands with soap and water before you mess with it. And then there's flushing. We like to flush the tube with just some regular water after medications or throughout the day. But typically it's not a lot of work. If you want to clean the area, you can clean it with soap and water. There's no specific, chemicals or cleaning material that you really need. There is one part where you can adjust the tube a little bit. So if I bring back this picture here, there's a barrier. Let's say this is where we made the incision site. There's a barrier right here. And so when you pull the tube, if you were to pull it this way, it pushes against the stomach barrier here, which is what we want. And then there's also a piece outside of the stomach that you can adjust as well. And so you kind of tug on that until you feel it pushing against the stomach. And then this outside piece, you can kind of nestle down just so that way it creates a nice area with the skin and inside the skin as well, inside the stomach.
All right. So Brian, I think having been through this procedure yourself, I would love for you to share your experience of having the surgery, and the aftercare and what it's been like for you.
Yeah, sure. For me, I let my symptoms get to the point where I really shouldn't have gotten, because I was using a lot of leverage and force and just kind of momentum to get around towards the end. So the recovery from this surgery for me personally was a little bit more than I expected, because just to get up out of bed, I really had to use a lot of torque and momentum. And with those incisions, I was like, oh my God, I think I might have ripped these stitches out, but it clearly I did not. But yeah, for me, I thought the recovery would be a little bit easier, but it's everyone's unique. But there was, I think, 3 small incisions in my stomach, and they were, I don't know, gosh, less than an inch wide, probably, for sure. And there was a little bit of discharge that came out of the port for the first probably couple weeks that I didn't know if that was normal or not. And Dr. Ospina assured me that was totally normal, and then that eased any anxieties I had. And after, I'd say after a month, it was all good to go. And I just keep a little gauze pad between my skin and it's kind of got a little, like a washer, looking like a rubber flexible washer that's on the outside of my stomach that does slide. So yeah, I mean, it was pretty easy, nothing too crazy. It's just my recovery was a little more difficult, I thought, than I was expecting, but I let my symptoms get to the point where I really did have a hard time getting around. And outside of that, it was, very straightforward, and I'm glad I did it. That's for sure. I mean, it's a game changer for me personally. There's no doubt about that. I mean, I would recommend it for sure.
Vanessa, can I speak to that as well?
Absolutely.
So like Brian said, he had 3 incisions. From what I understand, I believe we only typically do one right where that port was. So a different team might have done it where they made 3 incisions to get a better visualization of the stomach. But typically, like I said, we'll only do that one small incision where that port will ultimately go. And then, like you said, there will be some discharge from the area, and that's totally normal. Things you do want to look out for. Things you do want to look out for would be like a worsening red area that's growing, or some really white, stinky discharge. Those are signs of infection. Typically, if something were to get infected, it happens within the first few days. And after that, we almost never see it. We really hardly ever see it in the first place, but especially not after, the first few days are finished. Thank you.
Thank you for sharing that. So, Dr. Ospina, once somebody has had the tubes placed, how long before they're connected and the medications are started, and what's that process?
So we see them a week afterwards, and then we start to program the pump and do the infusion. And usually it takes about 2 visits to get your dose just right. And you have control over your pump, just like you have control over your DBS unit if you want to. And so that you can go up or down on either your morning dose or your continuous dose. And then you can also add that extra dose that we were talking about, like a rescue medicine. So we get started on the medicine. Our goal is to try to get to monotherapy if we can, to try to eliminate all your other medicines if possible, so that we're not taking so many medicines. Many times patients who have a lot of restless legs will keep them on the Nupro patch just to take care of the restless legs. But we will try to eliminate as many drugs as we can and try to just keep you on Duopa. Unlike DBS, where you have DBS and usually you're on most of the medicines that you were on pre-op, you're on post-op. So our goal is to try to minimize your medicines and minimize the dose of your medicines so that we have less trouble with side effects. And so usually a week later, whereas with DBS, we're going to see you a month later because we need all of that swelling to go down in the brain. And then we start to program the DBS after that.
And we did have a question. Someone wanted to know, why wouldn't you do this at the very beginning of treatment after diagnosis, meaning start Duopa early on?
Right. So, I mean, that would be the ideal thing. But right now, because it's a PEG-J, there is a procedure and you do have to maintain a PEG-J. It's much easier to take oral medicines today than at the beginning, and then transition to the pump. In the future, the next versions of these pumps will not need the PEG-J, and it'll be a sub-Q infusion like we have for the diabetic pump. So it'll be much easier to go from pills to pump, and people are going to go to the pump much sooner than they do now. I mean, now people wait forever because, like Brian, they're like, oh, I don't know if I want this tube hanging out of me. But I think once we eliminate the tube out of this whole procedure, then people will transition much faster into the pump, because you want the medicine to work like the normal brain. The normal brain gives you a continuous infusion of dopamine throughout the 24-hour period. It doesn't pulse you with dopamine every 3 or 4 hours and only during the day. Remember, when you go to sleep, you still have Parkinson's. And so we need to treat that. And so with a pump that we in the future will be able to run it 24 hours a day. Right now, the Duopa pump is only FDA approved to be on 16 hours in the day. Then we would be on like an insulin pump like our type 1 diabetics are.
And I actually had a question that came in earlier. This person said they experienced fairly extreme dystonia during off time, which is debilitating and really impacts their quality of life. Is this pump for continuous 24 hours, which you just answered? And if not, I will always deal with dystonia at the end of the day with or without the pump. Am I correct?
Right. So right now the pump is FDA approved for 16 hours. In my practice, about half of the patients are running it 24 hours, especially our dystonia patients who have a lot of dystonia at night. Then we run it for them at night and we lower the dose for them at night so they don't have side effects like confusion or hallucinations. And then the next version. So in the next 24 months, we're going to get 3 pumps on the market, 2 levodopa pumps and 1 apomorphine pump. So we're now entering the golden age of PD. We're not stuck in the Middle Ages taking Sinemet every 90 minutes. So we hope that we would get FDA approval of those 3 pumps in the next 24 months. Everything has slowed down because of COVID. They should have been out already, but I think they'll be finishing up their phase 3 trials and then submitting to the FDA. So hopefully last quarter of next year and early 2023.
Awesome. That's exciting news.
So the only thing is that then patients are saying, well, why don't I just wait until the FDA approves the sub-Q pump and I don't have to do the PEG-J? But really, like Brian, do you want to be off for the next 2 years waiting for the FDA to, get the paperwork ready? So I would say, remember, it's reversible. So we can start Duopa now. And then because it's reversible, when the new generation of the pump comes in, we take it out and we upgrade your pump to the new one. So there's no reason to miss out on quality of life because we're waiting for the FDA to get its act together.
And there was a question earlier also about age, if this has any bearing on eligibility or efficacy.
No, and in fact, so, one of the reasons we can't proceed with DBS is if the patient has mild cognitive impairment or dementia. And so we can't use DBS in those patients. With Duopa, there aren't any of those problems. So even if the patient has dementia, we can still use Duopa. It doesn't matter how old you are. It's a very easy procedure. It's like kind of like a colonoscopy as far as the anesthesia is concerned. So it's very well tolerated.
And a question for Kaler, this person wanted to know if this placement of 2 requires any special type of gastroenterologist with certain special skills, or is this something that any GI could do?
Great question. In our practice, we have a general GI team, and then we also have an interventional endoscopy team. Our interventional endoscopy team is the one that does this procedure. So there may be general GI physicians out there that place PEG tubes, that place that do this procedure. For us, for our practice, that's typically left to the advanced endoscopist.
Okay, great. Brian, so I know that a couple of people have asked about what all of this looks like. So I want to ask if you could show like what the infusion pump looks like. Sure. So they can see that. And I would love it if you could explain what your day's like with Duopa. What is the care, the stomach care? How has it changed your life? What's it look like? All that stuff.
Sure. Well, as Dr. Ospina said, some of her patients keep it on all day. I don't. I take it off about 9 or 10 at night. I have to be careful because then you're back on pills. So food has to be you have to be very disciplined about, not for me personally. The food has to stop. And I take the 2 Rytaris at about 10-ish. And then at 2 in the morning, I take just 1 Rytari. And that gets me all the way through to about 8:30 in the morning. Then I go through this. So I don't know if you can see this. So this is the pump. And I keep it on this little fanny. This is a compression shirt because I was doing like this thin little band. But this is just a whole like tank top compression shirt. So that's where it all is. I don't know if you can see it.
Yeah, we can see it. That's great.
And this is so I keep this little gauze pad between my skin and the like little washer. This is the tube that comes out. It's a little bit gross, but that's just the way it is. This is for this goes into my stomach. This red tipped part, which I just flush, but no medication at all goes into that. This is actually where the medicine goes into. And this is, let me get it up. And this is the pump. And this is my little computer I keep on. This is the cartridge right here. So this detaches from the pump. And this lasts 1 full day. And yeah, Dr. Ospina sets you up with like the correct dosages and what's specific for you. But yeah, I put this on about 8 or 9 in the morning. And then I leave it on all day and I pop it back in my little fanny pack like this. And I kind of curl that up like that. And I kind of just go about my day and forget about it.
And you said it was a game changer for you. So can you explain what's different since you've had the pump?
Oh, it's night and day. I mean, it's night and I'm a different person for sure. I mean, it's just night and day. I mean, you look back on the pills, they worked early on flawlessly, but once I had the blockages and the protein and the stoppages, I mean, this has just completely changed that. I mean, completely. So yeah, it's night and day for me. And yeah, there's a few inconveniences. There's definitely some care. You got to flush the tube every morning, every night. And I think there's some maintenance. I'm not 100% sure. I think they want to change it out every year to maybe 6 months, depending how active you are, I believe. But I'm not quite there yet. But and I did hear also, if it does get ripped out of you, I guess you don't even need to go to the ER. You just you can just tape it up and go into your doctor, and it's not like life-threatening or anything, is what I understand. So that took some of my anxiety out too, because every once in a while you slip up and the whole contraption falls. It gives you a good yank on the tube, but if you're careful, it's definitely a game changer for me, and I'm glad I did it. And thank you, Dr. Ospina, for reminding me it was available.
Right. So usually it takes patients about 18 months to say yes. And so many times after they have the procedure, they say, oh, I wish I had done it earlier.
So you would say that your quality of life went up?
100%.
100%.
For sure.
So are there things that you're doing now that you weren't able to do before? Any activities?
Oh yeah, I do yard work. I mean, I go to my boxing class, I go to the gym. I mean, you're certainly got to be careful about some things, but yeah, the body image thing goes out the window. So you got a fanny pack on. I mean, you get over that pretty quickly, but outside of that, there's really no limitations at all. You become like mobile again. For me, like being mobile was everything, and then timing things just became exhausting mentally. Now, like, you're in a restaurant and all of a sudden your pills go off. You don't even know if you're going to get to the restroom or out the door. That's a lot taxing your mind. Now that's all gone. You can get up, move around, and you're free.
That's
For me,
awesome.
it was freedom. For me, it was just freedom and independence again. It's like, wow, this is awesome.
Well, that's great. And I know we've had a few other questions about it too. So I'm going to go back to some of those. One person wanted to know, can you transition to this from pramipexole? Do you have to be on Rytary or carbidopa levodopa?
Yeah, so you can be on any combination of Parkinson's medicines and go transition to the pump. So if you're on pramipexole or Mirapex or Nupro or any combination of any PD drugs, as long as you're having off periods, which most patients who take Sinemet or Levodopa more than 4 times a day have some kind of off, then you would be eligible for the pump. And again, our goal would be that most PD patients are on 3 or 4 medicines. They're on some kind of levodopa, whether it's Sinemet or Rytary. They're on some kind of dopamine agonist, whether it's pramipexole or ropinirole or Nupro. They're on Azilect or Razagiline or a COMT inhibitor. And so if we can, our goal would be just to go back to monotherapy and just be on levodopa and not have to use all these extenders to make your levodopa last longer, because now you're on a continuous infusion of levodopa. And as Brian says, our goal is to give you independence over your day again and not have to worry about when my pill's going to kick in and how long it's going to last. So that mental taxing that Brian was talking about, where you're always worried about how much on time you're going to have and when that's going to wear off, that all goes away because you turn the pump on and then you're on. And if you need a little extra dose, then there's a button for that. And then you go on your day and you think about your day and not your Parkinson's disease.
Awesome. And we had a question. Someone wanted to know, how long will the pump work for the person? After 10 years, will the level of levodopa delivered by the pump still work?
Yeah, so the pump, so we can, the pump has, like Brian was showing us, it has the little computer part on the top and then the cassette in the bottom. And so as the disease progresses and we have to increase your dose of levodopa, then we add more medicine. And if you need 2 cassettes in a day, then we would use 2 cassettes in a day. So it would just be a matter of titrating the medicine, but you should be able to use a pump, just like you have DBS for the rest of your life.
And the medication, is that delivered to you, Brian, to home? Do you have to go get it? How does that process work?
Oh, okay. So that comes, there's a phone, you get a reminder. There's the number, I forgot the number, the Duopa number pops up on my screen, but they'll remind you, but you call and they'll schedule the shipment right to your house, FedEx. So yeah, that's very simple. It's got to be refrigerated. I don't know if we've mentioned that, but yeah, it comes to your house. I would say each carton, I don't know, I think there's seven in a carton. You get 4 of them, so there's a month's worth, and they're like the size of like a gallon of milk, maybe the whole box, you know. So there's a little bit of room in the refrigerator you got to create, but it's, you know, it's super easy. It just comes right to your house and they ship it to you with the syringes and all the things you need to kind of clean your port and all the accessories that go with it. The batteries do have to be changed weekly. They supply that also. That's very important, I was told, because they don't want to go kaput like in the middle of the day. I have to back up on one thing. I can't believe I forgot to say this. One great thing about the pump too is if you get ahead of this medicine, and it can catch up to you for whatever reason, all of a sudden you become really dyskinesia, and you start really moving all over the place. With a pill, you're stuck there. Like you're waiting that whole scenario out. You don't have any choice. With this, you can just turn the thing off, which really shortens up that whole span of misery. Like if you're overdosed on this stuff for whatever reason, because that can happen too. You know, if you're just not, for me, if I don't eat much, the medicine can catch up to me. So you have to be careful that way. And if I eat too much, I can still get a slowdown also. And that's what the extra dose is for. So just the flexibility of the computer is fantastic for sure.
Well, that's awesome. I did have a question come in, I think would be good for maybe Kaler. Someone wanted to know if an ostomy would interfere with the procedure.
That is a good question. I don't think so. So we recently actually had a patient in our office who had every abdominal surgery, you know, in the world. She's had it, and so we were, you know, originally concerned, but so with more history and talking with her a little bit more, she actually didn't have any surgery on her stomach itself. So that's what we're pretty concerned about, is if somebody has had for whatever reason surgeries on their stomach, because then the stomach can get scar tissue, and when that's the case, the medication port's a little bit harder to place. So for her, we just mentioned, hey, you know, we'll go in and we'll make sure that we can find a spot, and if we can't, then we won't. We won't force anything that won't work. But so typically, what, you know, the big concern is the stomach, because that's where the medication port is actually directly into.
And we had a question of whether you can sleep on your stomach with this, for those stomach sleepers out there.
Well, for me, with the pack, I don't sleep with the pack on, so I can't speak to that. I take the pills at night, but you can certainly sleep on your stomach. You just kind of tug. I wear a compression shirt all the time, just kind of keep the tube from getting all over the place. So yeah, I mean, I'm not a stomach sleeper, but yeah, absolutely, you could for sure. I haven't had any issues anyway. Personally, you know, everyone could be different.
Okay. And I think this may be a question for Dr. Ospina. I'm kind of interested in this answer too, is how many women versus men get Duopa? Do we even know if there's a difference? We know there is a little bit with DBS.
No, I'm trying to think in my practice. It's maybe slightly a little bit more men, but that's because there's more men that get Parkinson's disease. So I don't think there's a big difference, but there's no gender problem difference in getting Duopa or DBS. I mean, in the US, slightly more men have Parkinson's than females. So, you know, they tend to be on more therapy than female patients.
And this is typically covered by Medicare and insurance.
Yep, so it's covered by your Medicare A and B, so it's not your Part D or your prescription plan. So the whole thing should be covered. And then if there's any copay, then we can usually ask for some foundation support. But we haven't had any trouble with patients not being able to afford it, like we do with patients not being able to afford medicines like Rytari or the rescue medicines. So it's Medicare A and B. Because it's a procedure with a pump, and then they send you, like Brian says, they send the medicine directly to you. If you're a snowbird, then you just tell them, look, in the winter or the summer, I'm in Wisconsin or Michigan, and then they just mail it to your other home. They can mail it to anywhere in the United States, not outside of the United States. So if you're going to travel, you want to make sure it's less than 4 weeks, because you're going to get 4 weeks at a time.
All right, this is awesome. All right, and I did have one question, and again, this is, we're all wanting just to make sure we fully understand things. So this person wanted to know, does the progression of Parkinson's destroy the receptors for Duopa? So this device, just like DBS, will not stop the progression of Parkinson's?
Right. So like DBS and like your medicines, it doesn't stop or reverse the progression of Parkinson's disease. And it only treats your motor symptoms of Parkinson's disease. And so in Parkinson's, unlike Parkinson plus syndromes and other diseases, the problem is in the presynaptic neuron, not the postsynaptic receptor neuron. So as long as you're getting dopamine, that postsynaptic neuron can absorb the dopamine. So as long as we give you the dopamine, you should be doing quite well. So it doesn't, it's not like a Parkinson plus syndrome where it's the postsynaptic neuron that can't absorb the dopamine and use it. So it just gives you a more continuous delivery of levodopa, and it should continue to work for the rest of your Parkinson's life.
Awesome. And I'm going to take just a minute and I want to share my screen. For those of you who may not have been to this part of our website, on pmdalliance.org, we do have under our resources, treatment options and financial assistance information. And if you scroll down here, you can click on this button and it is going to take you to the page that shows you all of the FDA approved treatments that are available. And as you can see, Duopa is listed right here. You can click directly on there. It'll take you to AbbVie's site and it'll talk to you about all of the information that we've gone through and some more in regards to like their Duopa Connect, which will help you to connect with somebody, a mentor that will work with you, as well as a nurse, I think, that helps you with the process. And we also have the More You Know video series, which will give you a 3 to 5 minute, oh, and look, it's Dr. Ospina again, who does a very quick overview of Duopa and explains it. So you can always go back and watch these as well. You can go directly to the AbbVie site, and we have these for all of the FDA approved treatments, as well as all of the videos for all the FDA approved treatments. So I just wanted to share that with everyone. This video will also be up in a day or two. So if you want to go back and review it, it's been recorded, and you can go back and share it with somebody maybe that missed the program today and wants to learn a little bit more about this program. So I see that Kelly also put up, the links to the More You Know series or treatment options and the Duopa website. So if you want to go there and learn some more about peer mentors, although we had a fantastic one on here today with Brian. Brian, you've been fantastic sharing your experiences. It's always so helpful to hear from people who have actually lived it. So thank you for being so kind to come and not only share your story, but actually show your equipment. So that's fantastic. I also want to thank Kaler for coming along and being a part of this team today and sharing his expertise and kind of helping us understand from the surgical end of things how all of it works. And Dr. Ospina, of course, we thank you always for sharing your expertise and just giving us a very easy to relate to understanding of this medication option, when it's beneficial, how it all works, because it is a bit confusing, I think, sometimes. And so thanks for demystifying it a little bit. So thanks to all three of you for joining us. And I want to invite everyone to give them your thanks to you as well by the wave of gratitude. And I will tell you before we sign off too, if anyone wants to save the chat, because we did put links on there, the best way to do that is go down to where you write your chats, and you'll see the far right, this little 3 buttons, and you click on there and it'll pop up a box and it'll say save chat. And if you do that, it'll save it to your computer so that we can go back and you can read the chats and get those resources that were listed on there, just in case you missed them. So thank you all for being a part of this. And I want to just, again, invite everybody to wave their wave of gratitude to you as we thank you for joining us today. Thank you, Dr. Ospina.
Thanks,
Thank you,
Brian and Kaler.
and
Thanks,
Brian.
everybody.
So much. You guys have a wonderful day. Enjoy the rest of your afternoon.
Bye-bye.
Bye.
Thanks, everyone.